Hi everyone, good afternoon. Welcome back, and we're excited to continue the sessions for this afternoon. During the presentation, if you have any questions, feel free to throw them in the chat. And if you want to ask any additional questions after the presentation, you can also raise your hand, and we'll get to you after the panel discussions. I'm very happy to introduce Dr. Naheed Jibraj, and today he will be presenting on selective decontamination of the digestive tract in intensive care unit patients. And I will pass the floor to him now, and he will just begin his presentation. Sorry, I'll just get rid of this screen. 1 second, sorry. Perfect. Go ahead.
Great. Good afternoon, everybody. My name is Naheed Jibraj, and I wanted to start by thanking the amazing conference organizers and the many investigators and educators who have developed the Pragmatic Trials Training Program. I'm sure many around the room can agree that the content, teaching, and experience has been nothing short of amazing. I can't believe how much I've learned in such a short period of time. I don't know how much I'll retain, but I'm working hard at it. Today, I have the opportunity to discuss our protocol for a cost-effectiveness analysis that we designed alongside the selective decontamination of the digestive tract in ICU patients cluster crossover randomized control trial. Our research question is, among critically ill mechanically ventilated patients, that's our population, is the use of selective decontamination of the digestive tract, or SDD for short, as compared to standard of care without SDD, cost-effective for the prevention of patient-important outcomes like quality-adjusted life years and mortality. So what is selective decontamination of the digestive tract? Well, it was originally described in immunocompromised patients, extended to trauma patients, and then ultimately extended to critically ill patients in the early 80s. It represents a cocktail of three things: an oral paste, a gastric suspension, both of non-absorbable antimicrobial agents, and a short course of intravenous antibiotics. And its purposes, or its suggested benefits, amongst many others, are to prevent the development of ventilator-associated pneumonia, which a complication of being on a ventilator and is associated with prolonged length of stay and increased hospital costs, and also reduce mortality. However, its widespread use has been relatively low, despite systematic reviews on the topic demonstrating both mortality and other benefits. And this is largely due to a concern around its ability to cause antimicrobial resistance or change the ecology within a given intensive care unit, as well as the small trials that were done in the early 80s and 90s. And so in this context, the Sudoku randomized control trial was started over a decade ago as a pragmatic cluster crossover randomized control trial, where the population were adults who were mechanically ventilated on admission to ICU and predicted to remain ventilated for about 48 hours, or at least 48 hours. The intervention of interest was SDD, which is this cocktail of oral paste, gastric suspension, and an IV antibiotic, so long as the patient wasn't already on an antibiotic with gram-negative coverage. The comparator was standard of care. And for this trial, the unit of randomization was intensive care units, where they had two alternating 12-month periods, one 12-month period in the intervention group and one intervention period, and one period in the control group. And this was separated by a 3-month intergap period. Now, this design was chosen as I discussed earlier. There's evidence to suggest that the intervention itself, selective decontamination, may change the ecology, flora, and antimicrobial resistance patterns of the unit. And as such, there's probably a cluster level effect that could derive or drive some of the benefit or harm. The outcome of interest was a 90-day mortality, and they looked at a variety of other outcomes, including days alive and free of mechanical ventilation, health-related quality of life, which is what we're going to spend today talking about, and then other interesting microbiologic and ecologic outcomes. The trial's taking place in Canada, the United Kingdom, and Australia. And the Australian component of the trial has been published in 2022, where they demonstrated that about 27% of the patients in the SDD group died relative to 29% in the standard of care group. And so while there was some absolute and probably clinically important reduction in mortality, this did not reach statistical significance. So why do we do a cost effectiveness analysis? Well, I think it's really tempting to think of healthcare as a unlimited resource, and we often treat it that way. But a question posed by policymakers and now very recently funders is how can we maximize benefits in the setting of limited resources? And a cost effectiveness analysis is one mechanism or one tool that we can use to facilitate this. I think the second reason is that critical care represents one of the most expensive endeavors in medicine. It costs about 1% of GDP in Canada and the United States and 0.1% of GDP in the United Kingdom, a number which was astounding to me. And so identifying opportunities to save money while improving outcomes or even leaving outcomes the same is an enticing goal. The third reason, and this is a very busy slide, so I apologize, but I'll get to the point, is cost effectiveness analyses have the potential for system level impact. In one of the most impressive cost effectiveness analysis studies to date in Canada, Fowler and the ProTech study investigators evaluated the cost effectiveness of dalteparin versus unfractionated heparin for the prevention of venous thromboembolism in critically ill patients. Now, if you've seen this trial before, you'll know that there were no statistically significant differences in rates of thrombosis, DVT, or major bleeding. Now, there were fewer episodes of pulmonary emboli and a complication of heparin known as heparin-induced thrombocytopenia among patients who received dalteparin. The trial, of course, was impressive, findings important. However, it probably wasn't enough to convince policymakers to pay for a more expensive drug at the time. Indeed, heparin was only $3 a day, and dalteparin was $8 a day. So what they did in this cost effectiveness analysis is they attempted to cost every potential driver of cost or attributable cost to each side of the equation, unfractionated heparin and low molecular weight heparin. They counted the medications, the laboratory tests, radiology, procedures. And to ensure generalizability, they obtained these costs from 25 centers in 8 countries. The approach was certainly resource intensive, but the impact profound. Because what they demonstrated was that the median cost per patient per day was lower for a patient receiving dalteparin across the globe. And they were able to translate these findings into something actionable. They demonstrated that the price of dalteparin needed to exceed nearly $180 a dose before it became cost ineffective. So I think this might represent a significant benefit of incorporating cost effectiveness analysis into clinical trials. When the primary outcome data is not very compelling, improvements in cost effectiveness might be. Now, before I start, it's important to recognize that there are many different ways to do a health economic evaluation. Cost effectiveness studies are used, and the reason we've chosen one is we use them when we expect the intervention to have an effect on both cost and outcomes. So we think it will affect cost in that the SDD drug costs more money than the standard of care. And we think that effectiveness will be different. Otherwise, we wouldn't have done the trial in the first place. So we're going to be focusing on a cost effectiveness analysis today. Very briefly, we'll talk about the population that we chose, the outcomes of effectiveness and cost and how we'll evaluate them, how we'll interpret the results, and then where we're at with respect to the protocol and some of the challenges that I'd love your help with. I'm not going to spend too much time talking about the intervention and how it was implemented because I think that more closely reflects the trial itself and not the cost effectiveness analysis. So in terms of our study design and sources for this economic evaluation of the cluster crossover trial, we're using both clinical trial data to get the effectiveness data and population-based health administrative data at ICES for cost and utilization. The population of interest are the mechanically ventilated patients who were included in the Sudoku trial, but only in Ontario. So the 7 centers in Ontario between 2019 and 2022. We only excluded patients if they couldn't be linked to health administrative databases, so if they had an invalid health card number or if they were a non-resident of Ontario. And with respect to sample size, there are many ways to do a sample size calculation for cost effectiveness analyses. Some center around the cost side of the equation, some center around the effectiveness side of the equation, and some try and incorporate both. For our sample size calculation, we just focused on the effectiveness side of the equation, and we used the same intra-class correlation coefficient as the trial used, targeting an 80% power, alpha of 5%, and we looked at a minimally clinically important difference in effectiveness using something known as health utility, and I'm going to talk about this a little bit later. But evidence suggests, or consensus maybe suggests that a utility difference of 0.074 is important, and I'll get to what that means shortly. And so in order to detect this difference in our population, we needed to recruit 40 patients per cluster for a total of 560 patients. Unfortunately, we were only able to recruit 460 patients for the trial as opposed to 560 that we needed. So we might be slightly underpowered to detect meaningful differences in utility, depending on the effect size. How did we consent patients? For the trial itself, for the main trial, patients in the intervention arm had individual deferred consent after enrollment in the trial. For the cost effectiveness analysis, we engaged in prospective consent in both arms. So it didn't matter if you're in the control or intervention arm, we asked for your consent to participate in the cost effectiveness analysis. When thinking about cost effectiveness analysis, one of the big questions we need to ask is who cares? And by that, I don't mean to imply that nobody cares, but instead, whose consequences are we considering here, both on the cost side and on the benefit side? Most commonly, we're talking about benefits to the patient. And most commonly, we're talking about costs to the healthcare sector, direct costs such as the cost of your hospital stay, for example. So in this context, for both feasibility and to ensure our cost effectiveness analysis remained pragmatic, we took the perspective of the Ontario healthcare system. In theory, one could look at broader society at large and the costs to society of a given intervention. But again, because of feasibility, we were unable to take this view. The next question we need to ask ourselves is how long are we talking about here? And this is something known as the time horizon. So you could do a time horizon to the end of somebody's hospitalization all the way to the end of their lifetime. And many of our modeling studies will go to a lifetime time horizon. However, both again for feasibility reasons, but also face validity reasons, we've taken a 1-year time horizon that we'll use for this cost effectiveness analysis. So we accrued patients between May 2019 and December 2022. We're following them up till December 2023. And that allows for a 1-year observation window or follow-up period. So this summarizes very briefly what I've just discussed in terms of study design, the population, our comparators of SDD versus standard of care, the perspective of a healthcare payer of the Ontario healthcare system, and our 1-year time horizon. And now I'm going to speak to our primary outcome, which is cost per quality adjusted life year. And so we need to talk both about effectiveness and cost and how we're going to get those things. So first is effectiveness. There are many measures of effectiveness. The easiest measure of effectiveness is something we would define as a natural unit. So these are outcomes that we can very easily count. And they're useful when one is interested in a binary outcome and don't want to incorporate any other consequences of the strategy that we're comparing. And so the natural unit outcomes that we're looking at are resistant organisms, ventilator-associated pneumonia, and death. And I'll talk about how we'll measure those shortly. Now, since these interventions almost always have multiple consequences, we had to obtain a more holistic outcome. And a holistic outcome that considers almost all the consequences after a patient's stay is typically based around somebody's quality of life. And when we're talking about healthcare, we're usually excluding external circumstances and focusing on health-related quality of life. And health-related quality of life can vary over time. There can be progression of disease or development of a new one. Interventions like an ICU stay might initially harm and later help, and there's a natural decline towards death for most people. So we needed a measure that we could multiply by time. And so this is something known as a quality adjusted life year. And the most common measure or way to get a quality adjusted life year in cost effectiveness studies, which suits all those needs, is something called a health utility. It's on a scale anchored at 0 for death and 1 for the state of being in perfect health. It's an interval scale, so the difference between 0 and 0.1 is equivalent to the difference between 0.9 and 1. And it allows us to multiply by time. And the number that you get represents a preference for a health state that's relative to these two anchors of 0 and 1. And so how do we get a health utility? Well, we typically use a method known as indirect elicitation. So there's 2 steps to this. Part 1 is to identify the health state an individual is in. So that's most commonly operationalized using a questionnaire. There's 2 very common ones. The one we used for this cost effectiveness analysis is something known as EQ5D, and it evaluates mobility, self-care, usual activities, pain and discomfort, and anxiety and depression. The next step is to convert the answers to this survey into a health utility, and this is typically validated in the country in which you live. So for example, in Canada, the responses to the EQ5D questionnaire translates to utility values that range from minus 0.49, which indicates a preference that Canadians identify as worse than death, all the way to 1. So our effectiveness measures are health-related quality of life, which we measured at 90 days, or quality and health utility, which we measured at 90 days, and again at 365 days. And this brings me to our second challenge, which was that measuring health-related quality of life is very difficult. If patients were still in hospital at 90 days, then we could do this in person. If not, as planned in our protocol, we did this over the phone with the patient themselves or with an SDM with the patient next to them. However, at this point, with these 2 approaches, we had about a 40% loss to follow-up, which is exceedingly high. And so we subsequently mailed letters to all the participants who were unable to be contacted via the first 2 methods. And we've now got about a loss to follow-up of about 19%, which was what we had predicted at the outset. In terms of other outcomes, we're looking at in-hospital mortality, which is measured in both, which we'll use clinical trial data for. ICU-related bacteremia, which is also in the clinical trial data, and ventilator-associated pneumonia while in the ICU. Then the next outcome of interest, of course, is cost. And so there are many different types of costs that we needed to consider. There are direct costs, which are the most obvious ones. These are, the cost of your medical stay, or even non-medical costs, like, the taxi it took you that you had to pay for to get to the hospital. And then there are indirect costs, such as the opportunity cost of being maybe disabled after your ICU stay. So this could be a loss of income or your caregiver's loss of income. And then there are intangible things that are hard to put a dollar value on, like pain or suffering. And so we typically put that on the effectiveness or quality of life side of the equation. For the purposes of this study, we have focused on direct medical costs. And so how do we get these costs? Well, what we did is we looked at the previous literature and we developed a line item list of potential cost drivers that might exist within an individual stay and directly related to the intervention itself. So we created a very long list, and then we worked as a team to pare it down. That included categories such as medications, laboratory and microbiology, C. diff infection, radiology, the cost of the personnel working in each of the units, procedures that an individual might have undergone, and hoteling costs. And then what we do is we count up how many of these things occurred, and we multiply it by however much it costs. So some of these counts will come from the CRF data, while other of these counts will come from linked health administrative data at ICES using ICD-10 codes, OHIP billing codes, the Ontario Laboratory Information System, amongst others. How will we get the costs themselves? We'll use sort of like a hierarchical approach. We'll look first at public databases, whether that's the hospital formulary for cost of drugs or the schedule of benefit for cost of services. If the cost of a given intervention is not available in one of these data sets, then we will go to two of the participating centers and ask their case costing initiative offices how much specific things cost. Now, unfortunately, many of these units only know how much they charge for a service rather than how much it costs. So there is a charge to cost ratio or calculation that we can use to begin to estimate how much it may or may not cost. Finally, if after those two do not work, then we will look at previous studies in critically ill patients in Canada who have obtained costs for some of these line items and use those costs adjusted for inflation. So this approach is great because it allows for granularity. It allows for us to understand what might be driving some of the difference in costs between groups. However, the challenge is it reflects only the costs incurred during an individual's hospitalization. You can't see anything after they're discharged, though, unless they come back and experience any of the things that exist in this line item. And of course, people could be discharged home and have increased disability or require nursing home care or required mental health support. And those would be more difficult to capture using this approach. So we're going to take a second approach to costing after discharge from hospital using health administrative data. And as many of you are aware, at ICES, there's a get cost macro that leverages a variety of health administrative data sets to aim to capture the costs incurred by the Ontario healthcare system for a given patient's hospitalization. We're going to measure this at 3 time points, at the discharge from hospital, at 90 days, and at 365 days. And the reason we've chosen these timeframes is to match our effectiveness data. The major challenge with this approach, or using it exclusively, is that the cost of a hospitalization estimated using this approach is not very sensitive to smaller cost differences between patients. For example, it wouldn't be able to tell us the difference in cost between a 1-day difference in ICU length of stay, for example. And so it makes this approach slightly less sensitive to the previous one. And so we're going to use a hybrid approach of both. So once we obtain costs and once we obtain effectiveness, the next question is, what do we do with them? Well, the first thing we will consider is whether or not we have a contest. And what I mean by that is if SDD is deemed to be more effective and less expensive, then no further analysis, well, some sensitivity analysis, of course, is required, but no further calculations are required. In other words, this is dominant and we should certainly use it. If it is less effective and more expensive, then we probably shouldn't be using it. But where it's most interesting is if it's more expensive and more effective, or less effective and less expensive. And in this context, when we're in this in-between where cost and effectiveness are going in the same direction, we have to consider how much different the costs are compared to how much different the effectiveness is. And that's something known as the incremental cost effectiveness ratio. So we'll take all the costs of all the patient in the intervention arm and average it. And we'll take all the costs in the control arm and average it and look at the delta. We'll do the same for effectiveness. And we'll do this for our primary outcomes, cost per QALY at 90 days and at 365 days, as well as per in-hospital death avoided and per ICU bacteremia avoided. And then we'll have to ask the question, well, how much is somebody willing to pay for 1 year in full health? Or what is the correct cost per QALY? And that's a really subjective decision. But if we consider what society generally thinks and what most researchers have used in the recent past, it's generally agreed that the healthcare sector is willing to pay about $100,000 per quality adjusted life year, or 1 year in perfect health. And so we'll use a willingness to pay threshold of about $100,000. In terms of subgroup and sensitivity analyses, we'll look at specific subgroups who this intervention might be more cost effective in or less, including surgical patients, trauma patients, male versus female patients, as well as severity of illness. We'll, of course, assess uncertainty in our estimates, but that statistical plan is still pending given the clustered nature of our data. And so we're getting some advice on that. And in terms of sensitivity analyses, we'll look at the probability of cost effectiveness across a variety of different willingness to pay thresholds. So not just the 100,000, but we'll look lower and we'll look higher. We'll vary things like drug costs, hoteling costs to ensure generalizability, as well as varying the time horizon and the costing methodology that we've used. In terms of our current status, we've finished patient recruitment and followed patients for 365 days from an effectiveness standpoint. We've activated our project at ICES, and we've linked the trial data at ICES. We've drafted a dataset creation plan. In terms of next steps, we are working on identifying line item costs, or what the various line items cost at the two centers. We're working on a statistical analysis plan before we see the data, and then we'll kick off our meeting at ICES. I've highlighted most of the challenges throughout this presentation. I think the big ones were ensuring recruitment to 560 patients, challenges with loss to follow-up. There's always a risk when you're using health administrative data of misclassification when we're using ICD-10 codes or procedure codes to count data or to count outcomes. And we're working on an analysis plan in the context of the clustered data. So thank you very much. These projects do not happen without mentorship from a variety of different people. In particular, I'd like to thank Dr. Rob Fowler, who's been a mentor throughout this cost effectiveness analysis. And I look forward to hearing questions from the panelists and from all of you.
Thank you, Nahid. That was a really great presentation. And we'll just move on to the panelists. So I'll just introduce everyone. We have Dr. Brian Cuthbertson on the line with us, and he will be asking some questions. And we also have Ahmed Ali Jaishi, and he's going to also contribute some questions. And we'll just go in order of the images that you're seeing on the screen right now. So we'll start with Brian, and everyone will just ask one question, and then we'll go around and see if there's any additional ones afterwards. So I welcome everyone, and let's get started with the questions.
Yeah, thanks, Nahid. Enjoyed your presentation and quite a nice general review of the topic as well as specifics of this trial. This trial has now recruited 20,000 patients worldwide. So you've sampled 500 patients of the 9,500 that are in the RCT, and you mentioned the clustering issues. Just tell me a little bit more about the potential challenges of the sampling framework you've used and how you're going to deal with the clustering in your analysis.
Thanks, Brian. This is a great question. So firstly, the biggest challenge or the biggest risk here from sampling 500 patients of 9,000 at a few number of sites within Ontario is that we're at high risk of some degree of selection bias. And I haven't seen the data yet, but there's a risk that our patients are sicker or less sick than the general population, or have more surgical patients or less, or more trauma patients or less, depending on where these patients were recruited from. There's not a lot that we can do about that, but I think what we can do is we can do some sensitivity and subgroup analyses to try and get at to try and better understand perhaps whether there's a specific population in which this intervention is more cost effective in. When it comes to clustering, I'm still working on that with respect to the statistical analysis plan, and I see here we have an expert on that on the call who's also going to be asking me some questions. So I look forward to perhaps some of his feedback in that regard.
Thank you.
Thank you, Nahi, and very, very interesting talk. This is one of my favorite topics. But I haven't done many cost-effective analyses. Just a little bit about myself. I'm an epidemiologist, and I work with the Pragmatic Trial Services Group. A lot of my work centers around methodology for conducting cluster randomized trials with a focus on trials within the hemodialysis area. So my first question, and you kind of touched on this in your talk, is the rationale behind choosing a 0.074 minimally important difference for the EQ5D5L. Can you give us an idea of what does that threshold mean with respect to like a perceptible quality of life improvement from a patient perspective, specifically more in the ICU setting? So how does that change the person's life or quality of life?
Yeah, that's a great question. So as discussed previously, so this number was determined based on a few systematic reviews, which indicated that society at large believes that 0.074 is an important number in terms of improvements in quality of life. The truth of the matter is that, as you very well know, a health utility just represents a preference for a specific health state at a specific time point. And so it's very difficult, I think, to begin to be able to talk about health utility in terms of differences in function. And what I mean by that is, most of us, or at least I, would want to say, okay, is 0.74 mean that I can write an essay when I couldn't write an essay before, or I can feed myself when I couldn't feed myself before? And actually, what we know about health utility more broadly is that if I use the same scale in somebody with a C-spine injury who had very different function at the outset of when I measured this, who believes they have a very good quality of life, might report their health utility as being quite high. Whereas for somebody like me, who's had great function today, if I had a C-spine injury and you measured my EQ5D with the same level of function as the other person, my health utility would be very low. And so I think that's, I think that the 0.074 to me, I equally struggle with a number like that. But I think it speaks more to how health utility is measured and what it reflects.
Thank you.
Brian, did you have an additional question?
No, that's fine. I enjoyed the answer to that last question, though. Thanks.
Maybe I'll ask another question. I have a few questions. Some are just interest given the time patients were recruited. So I think when I saw your timeline, patients were recruited between 2019 and 2022, which happens to be during the COVID-19 period. Especially, at the beginning of the pandemic, there was a lot of mechanical ventilation and shortages in ventilation, especially for areas where there was a high ethnic minorities who continued to work, and large academic centers were generally more impacted. Can you just talk about understanding that this is a cluster randomized trial? Can you just talk about the challenges that you encountered during the trial, and specifically around the COVID-19 pandemic with respect to both this analysis and the larger trial? And I see you smiling, so
No, I'm smiling because Dr. Cuthbertson here on the call had to navigate a lot of these challenges. So with respect to the cost effectiveness analysis specifically, we were fortunate in that most of the patients recruited in the cost effectiveness analysis were in the latter half, so in 2021, 2022. And so I think from a recruitment perspective, at least with respect to the CEA, we did not experience significant challenges from COVID-19. That being said, as you very well know, many large trials were halted during the COVID-19 pandemic, and so it no doubt force us to pause recruitment of patients around that time period, and may reflect why sort of, certain countries had published the trial before others.
I guess the last question I have is with respect to your sample size, which you talked about in length. I think in the information that were provided to the panelists, the planned analysis was aiming for recruitment of 700 patients. I think the final enrollment you mentioned was 459 patients. I understand that you conducted your power analysis based on the effectiveness portion, and you powered it to have 80% to detect a difference if one existed. So can you just talk about the strategies that you're considering to mitigate the potential underpowering of this analysis?
Fantastic question. I don't know that I know the answer to it just yet. I only found out this information just shy of a month ago, so we're working on it. But I think probably I think once we see the effect size, maybe we'll be able to have a bit more insight into what we would do next. But unfortunately we can't recruit any more patients, so I think we're stuck with where we are.
Yeah, you made the terrible mistake of doing a power calculation in the first place.
Yeah, exactly.
And so that's the problem here, is because most people, the vast majority of cost effectiveness analysis ever done, have never had a power calculation. So we've made a rod for our own back. We now have the first ever underpowered cost effectiveness analysis. Ahmed, if I can just say one or two more things briefly about the discontinuation of the trial. This is an even bigger problem in a cluster than it is in a parallel group. And it's an even bigger problem with this intervention than it would be in a cluster. And the reason is that we were indeed stopped in March, April 2020, according to the Ontario government's requirements. And then again, the year later, because we couldn't get the drug delivered for COVID reasons too. When you have a cluster, you offer an intervention for a fixed period of time, as you well know. And so if you have to pause it, then you have to then have a break in that period of time and then continue it and add the month or whatever on at the end. But it's even worse than that, because if you're doing an intervention that you think has indirect effects and might drive antibiotic resistance in one direction or the other, and you believe it's about penetration of the intervention over time, then you've actually lost some of that penetration by breaking your intervention period in two. And therefore you may have affected limited or perhaps increased the drive on antibiotic resistance that might be occurring indirectly in the units as a result of this antibiotic intervention. So it's very challenging in a cluster trial, unfortunately.
Yeah, absolutely. And I mean, I think you touched on this as well as say, for example, you discontinued at 10 months and then you continue at a later time it takes for the treatment effect at the cluster level to, kind of take more or less, like take full effect over time could vary across clusters. So by the time you finish your 2 months follow-up, depending on which arm you're in, you could potentially you could potentially be attenuating the treatment effect had you continued that final 2 months without discontinuation. So it's definitely an unfortunate thing because you have almost 2 levels of contamination, the cluster and the patient, where the cluster, as you mentioned, there could be over time, you can see reduction in different types of microbes, and if those are paused over a long period of time and then the trial continues, you might not have that when you do continue the trial.
It's a bit imponderable because it could be that the effectiveness has been reduced by the pauses, but it also could be that you've driven the resistance less.
Mm-hmm.
So it becomes a bit imponderable to work out what impact this has had, but it certainly reduces the internal validity of the study for reasons that are out of control, as you can imagine.
So then I wonder if the analysis might have to consider some form of adjustment for the pauses, and I would welcome any other anyone outside of the panel as well for the pauses and potential temporal effects given the pandemic.
Yeah, and I'll happily invite other people's comment, but the bottom line is Australia recruited 2/3 of the RCT patients, and their effect sizes and directions are the same as the entirety of the international cohort, and indeed of Canada separately. So there's no very obviously measurable effect if you treat that as a sensitivity analysis, but it's a very nuanced thing.
Did we lose Brian? Or is it me?
No.
It's stuck on.
It's frozen.
Give it a couple of seconds. See if he is able to come back.
So maybe Nahid, while we're waiting, this is maybe that may be of interest for others on the call. Can you maybe just provide some insights about patient linkages with the ICS data or administrative data, and if there were any challenges with linkages between the two groups, and what kind of just barriers you encountered during that process, or maybe.
No. So I'll start by saying it ended up being relatively smooth. However, there were a few lessons for me for next time. So first and foremost, clinical trial data can be linked to health administrative data at ICES, so long as we have consent from the patient to share their Ontario health card number and clinical trial data with ICES. So we had obtained that consent. Despite a few purporting to have a valid Ontario health card number, one of the challenges that we experienced was that just shy of a few percent of them did not. And we had to go back and try and figure out what their true Ontario health card number was. So that was one challenge that we experienced. And so we were concerned we might have a smaller sample size after all that, but that ended up being okay. The second challenge is that there is a time lag between when you do get your RCT data and then when it's ultimately linked to ICS, which was a few months, but that's ultimately been done now. We have not seen the subsequent outcome data just yet, and we're working to get that. But there are a variety of different data sets, as you know, Ahmed, that are available at ICS that extend across a variety of cohorts and outcomes, including sort of most commonly are the CHI databases that account for acute inpatient hospitalizations, but then there's also drug monitoring, ODB, opioid use, and so on and so forth. So this allows us to connect to a variety of different data sets based on Ontario Health Card number.
Thank you, and I'm done with questions.
I see Brian's. We got Brian back. If he has any additional comments or questions.
No idea what you heard. But yeah, the point that I was making as I got cut off is just how challenging this is when you stop a cluster trial that has multi-level effects potentially on the environment.
Good. I'll invite the audience questions now. If the panel wants to add anything else with relation to the audience questions, we can go back to you as well. So if you want to ask anything, just throw it in the chat or raise your hand. I see already we have one hand up. You can ask your questions now.
Yeah. Hi, this is Ahmed. Our video doesn't work here, but I'm at the coordinating center. Can you hear me? Yeah, thank you so much for this great presentation and talks. Just more commentary. It's interesting what was described first for the justification for the cluster, also this concept, as you mentioned, Nahid, like potential herd immunity, like there's immunity passing on beyond that one patient through the whole unit. And then what got my attention also is what the nice comment Brian made, like if you have disruptions in that, could that then attenuate the treatment effect? And then the final thing that came to mind in terms of design consideration, we do cluster crossover trials for the strengths of that design, if you are going with a cluster, is that you potentially are balancing the baseline characteristics and the center level effects, to reduce that source of variability, because many cluster trials aren't so large. So you're always concerned there's an inherent difference between the two groups. In an individual patient trial, sometimes some people have said you need like 1,000 patients in the two groups to be very confident that the baseline characters are similar. But in cluster trials, we often have small clusters. So that's one of the benefits of doing a cluster crossover. So making sure there's more balance there, and also statistical power. But then just reflecting on what Brian said, like that is an interesting point, that it does make you prone to disruption if something happens. Like we did a parallel group cluster trial in dialysis units that was also running during the pandemic, but there was no crossover. So once we embedded it, delivered by routine care, the pandemic had no effect. But I can only imagine if we had done something like switch people over now to the other arm in the middle of a pandemic, that would really been problematic, and then to create these extra timelines and lags and potentially attenuating the effects. So I just wanted to share some of those reflections with the nice conversation that was being made. And I'm not sure if anyone else has any comments on what I'm saying.
Yeah, Nahid was less involved with this. So in a cluster trial, you have to identify something called the ICC, intercluster correlation, that relates to just how similar clusters are. They're often very dissimilar. So that brings in a massive amount of variation. So I always say, if you want to do a mortality trial from a difference from 29 down to 25.5%, 3.5% absolute risk reduction using a individual patient RCT, you need 6,000 patients. If you do it as a parallel group cluster, you need 23,000 patients. And if you do it with a crossover that's very conservative, when this ICC, which says how different are units from each other, then gets reduced by a demultiplier, the IPC, how different is your unit from itself between the two interventions. And we only used 50% for these two, for the IPC, the second thing. That still you need basically somewhere between 10 and 15,000 patients. So these are massive multipliers because of that marked heterogeneity. And then final point is, that's why the consort statement says you must always do an adjusted analysis because these units are very different from baseline and onwards. And when you look at a cluster trial, ours is 20,000 patients, 9.5 in the cluster, you have to realize that that's not the same as an individual patient RCT of 9,500 patients. The important number is the number of clusters, not the number of patients.
Did anyone else have any comments with regards to that? We have one more question in the chat. Could you elaborate on the consent approach and its challenges to do the cost effectiveness analysis?
Yes, thank you very much for the question. So in contrast to how we did consent in the main trial, consent for the cost effectiveness analysis was done prospectively, where participants or their substitute decision makers were asked for consent to participate in the cost effectiveness analysis. In terms of challenges as with any trial is participants willing to take on the additional work of being followed for 365 days, and so recruitment was slightly challenging and slow to start, but improved in the latter half of the trial. We did receive some questions about the data being shared with ICES, but no, to my knowledge, no patient said no as a result of that. And then I see Roni had some questions. What's our hypothesis with respect to the cost effectiveness analysis? My hypothesis, based on some of the data from the Australian trial, is there might be a small cost benefit associated with selective decontamination, maybe driven in part by slightly lower mechanical ventilation or length of stay. And with respect to benefit, I think given that there was maybe a clinically important reduction in mortality associated with the, at least seen in the Australian data, my hope or feeling or hypothesis is that we might see that this intervention is cost effective. With respect to when results of the cluster randomized controlled trial will be available, I will say forthcoming and unsure. And with respect to the cost effectiveness analysis, our aim is to ensure that the two of them are aligned, but this is highly dependent on when we have our data available from ICES.
The paper's about to go off to New England Journal with the editor saying they're interested. We will see.
And Gordon, thank you very much for your question. Yeah, so I do believe, well, I think it's a very leading question. Thank you. I love that. Yes, of course, I believe that cost effectiveness analysis should be highly integrated into clinical trials. There are actually two big implications, or three that maybe we can consider as we move forward. The first is, of course, with respect to platform trial and platform trial development, because you can bake in cost effectiveness in two ways. The first is, of course, with respect to cost and outcome data collection, but more importantly, you can reflect on the cost effectiveness of the trial itself as you move through it. And so there are other platforms, particularly in the UK, that are not only just looking at the cost effectiveness of the intervention, but cost effectiveness of the trial itself. And I think that's, will that change the way we do trials? I'm not sure, but it's still incredibly interesting and important. And then through, in the course of this, I think the more challenging part is not measuring effectiveness, so long as we're measuring effectiveness at the time of the usual times of follow-up with a given patient. But measuring cost is increasingly difficult, and making sure it's generalizable across countries is very challenging, particularly when the trials run across 3 countries. So of course, for ours, we've just focused on Ontario because it's easier and because it's practical. But I think identifying ways to start to build capacity to integrate cost acquisition at the time of enrolling a specific center into a trial would be interesting. Like, I think if we could have a list of costs that we think are attributable to the given intervention from the outset, and hand it to each center at the time of enrollment to see if maybe they could work with the local cost center as part of every single trial. We could probably begin to develop some baseline costs of specific things that we could then just use over and over again for, within a given year for a specific trial, for example.
Thank you.
Gordon, did you have any other additional questions or comments?
No, but mentioning the UK, that was my background and experience of working within trials done within the NHS. Cost effectiveness is obviously a very important aspect of why you want to do a pragmatic trial in the first place. So it's good to see that coming over here.
Yeah, as you say, Gordon, the UK has been doing this for 20, 30 years. It's interesting you still have to make the argument in Canada. Canada is such a centre for pragmatic trials, but yet the cost effectiveness thing is a battle that's yet to be won in this country, I think.
Very interesting points. Does anyone else in the audience have any additional questions before we wrap up?
I do maybe have just one that's kind of linked to what I've just asked Nahid, and more generally for everyone else. It's been a really informative week, and that question about what you've learned in the development of this, that I guess it can go to everybody who's presented or everyone who's developing a protocol, and that's maybe the point of the pragmatic course itself. But what have you learned? We've had some very detailed and some very extensive research going into what's been presented here, and yeah, I'm just curious about maybe how the course itself can spread those lessons learned across the accumulated experience to. I mean, maybe this is all beside the point, and that's happening anyway. But yeah, it's not really a question, more of an observation.
Yeah. I guess I can start, and maybe some of the other speakers can pipe in. But I think when we all go to medical school, the first thing that we realize is we just don't understand the language of medicine, and we spend sort of the first 3 years learning the language of medicine before we see and interact with patients, or see and speak and interact with patients. And I think for me, this course did exactly that. Like, I just did not understand the language of pragmatic trials, how to critically appraise them, the various methods, and what makes something pragmatic. And so I think for me, first step, just learn the language and then begin to implement into practice. But I think that's been a very large takeaway, and also just to see the amazing research that's happening across the country and the various protocols at various stages, which was incredibly informative.
It's very great feedback. And does any one of the other learners have anything they would like to just add to that? If there's no other comments or questions, then we'll just wrap it up here. And I want to thank Nahid for presenting today, and it was a very, very interesting and informative session. And thank you, Ahmed and Brian, for asking questions and commenting on his presentation as well. And today was the last day, unfortunately, but the sessions will be posted on our website post-conference. So we'll send out more information with regards to that and how you can access that information in case you missed anything during the conference, or if you wanted to look anything else up. And For the trial leaders, we will provide you with, whoever presented will provide you with the questions that have been asked during these sessions so that you can have that on hand in case you want to implement anything that you learned or any interesting questions that were raised during the presentations. And just as a reminder, we have a networking event happening locally in London tomorrow at Western University. So if you happen to be in Toronto or in London, then please feel free to join us. And that wraps up the week's worth of presentations. I really hope everyone learned something during this time. And we look forward to our next year's conference as well. Thank you, everyone.